Hello everyone, this is Bob Browner. This is our second year of our HPV vaccination initiative here in Lincoln, and some clinics outside of Lincoln may be using it, so it says Lincoln and Nebraska. So I start a lot of these presentations with why. Why are we doing this? And if you don't know this, you probably won't do as well. So let's start off with basically we have a problem in Nebraska and actually nationwide in that our HPV vaccination rates are much below Healthy People 2020 goals. So we've got a room to make some differences. The data is getting stronger and stronger that HPV vaccination does have a huge impact on the incidence of cervical cancers, genital warts, and probably later on likely throat cancers to some southerners as well. We're already seeing big drops in abnormal HPV types. The countries that are doing this well are already starting to see herd immunity. So when you start getting in rates of 50% hitting up to 80%, you do start seeing herd immunity, and we're starting to get closer and closer to that. So hopefully this will be part of an effort to do this in our community. There are other examples of successful efforts doing something similar, which we've done nationwide, and then also we've done successfully here in Lincoln. We had a colorectal cancer approach that had a similar 80% target that many clinics did meet. So our goal is 80%, which is the Healthy People 2020 goals. It would be really nice if a lot of our clinics were able to get it this year here in 2018. Other side benefits of this project, in addition to being good for your patients, of course, is that you do get 30 hours of CME credit and you get American Board of Medical Specialties Part 4 certification, which a lot of people don't like what's out there for Part 4 modules. This is a way to usually actually do something in your clinic that I think is going to be much more beneficial to your clinic and improving your care than the standard modules that are out there. So it's a bonus that you get credit for this. Other things is this helps you succeed as an ACO. It helps you get shared savings bonus, and I think style points potentially as well. So for example, Blue Cross Blue Shield is going to make adolescent vaccinations one of its ACO measures this year, and so your ability to achieve shared savings is partly dependent on your performance. And so there's also a financial incentive for ACO projects to do better. I have heard that Medicaid is planning to also use adolescent vaccinations as a quality measure coming up as well. And because Tdap and meningococcus are already there pretty much, it means that if you're not meeting that measure, it's primarily due to your failure to meet it on the HPV. So you can basically narrow down on your HPV vaccination rates, and if you improve those, you'll make it. Also style points. So our goal eventually is to have Lancaster County have the highest HPV vaccination rates in the state. This is an old report from DHHS. They're still fixing some of the Nessus issues, but hopefully this year they'll be able to give us an accurate measure of what our actual county level vaccination rates and closer to real time as Nessus gets better. But it would be great to have style points saying we're the best here in Lincoln. So timeline for the project. You'll have these quality presentations in February and March of this year. Your first baseline data poll will be April 1st. The mid-course will be July 1st. Final will be October 1st, after which you'll have your clinic discussions. And then by November 30th, you'll need to get on and do your attestation reflection. That's a requirement from the American Board of Medical Specialties. You'll have to do that individually. There's no way we can get around that. So it's your job to do that, if you want credit, of course. The other needs and expectations is we need to know by April 1st who wants CME and credit for this, so we can get your board certification numbers and have everything entered in the system correctly. The other thing is each clinic needs to designate a lead clinician. It could be MD, DO, nurse practitioner, PA, who completes the forms for the group and sends them to Mary Jo Gillespie. Individual clinicians, though, at the end will have to log on, as I mentioned. So the first deliverable will be with this form, and so basically right here there's Mary Jo's email. So once you finish this form, put your clinic name. It's a fillable PDF. You'll put in where you're at right now with your HPV vaccination rates and what your target should be, which I hope is 80% by the end of this year. You'll start describing some of your changes, and the second thing you will need to give us is the workflow diagram, which we'll kind of get into here in just a few minutes. So last year we used a quality improvement framework called DMAIC, which is used in Six Sigma with a little bit of a modification. It's been used in healthcare before with what I sometimes in this slide call the ultimate quality measure, which is dead, not dead, because there's not much to argue about there. It's worked using this framework in the past in healthcare, and we've used it previously. But I'm actually updating it to something else. This was put out by an internist, and I like this one because of his step, argue about the data, because so often our reports are wrong, and I think it kind of fully acknowledges that, which helps. It's an article written by David Scrace here, and I can send you a copy of the article if you'd like to read it. It's only 2 pages. I do think it is worth a read. But essentially goes through really what is DMAIC, but modified for medicine, and I like this approach, so this is what we'll talk through. So first, agree on standard of care. Well, it's HPV vaccination, a first one at ages kind of in that 12 to 13 we've defined as the ideal time to get it because that's when they're in for their 7th grade physical, and then getting that second vaccine by the time they're 13 to 16. We've got some tailwinds for this project in that it used to be a 3-dose series, and so getting to this 2-dose series I think is making it easier for us to do this. Plus there is evidence showing that if the vaccination series is given earlier, it is more effective than if it's getting later, like say at ages 17 or 18. So not only is it better, there's one less shot if you're doing it by the age of 15. So you fill out that form, get it to Mary Jo. The next thing is the collect some initial data on how you're doing. So example for this is an actual slide from a few years back with our colorectal cancer program. And what you usually need to go is find out, well, who's doing it well, who might not be doing well. Oftentimes this actually, it's why this person's not doing it well may be something that's just a technical problem. Maybe the data's wrong, maybe there's a workflow issue, but learning from who's doing best is often the best place to focus on. It's also good to look at your peers, and so this was the end of last year's HPV vaccination project, and you can see that some people did much better than others. One group actually did get pretty close to that 80%, so I suspect this year we'll start seeing a lot of these groups hitting 80%. Some I don't think made some progress, and we'll talk a little bit about what I think is probably happening with the variation in who's doing better and who's not. Second thing is argue about the data and then moving to improving the data and acting on it. And so you start with the report, and what you're really looking at is who didn't get vaccinated and what should we do about it. This is sometimes called a gaps in care report, which is the way Blue Cross Blue Shield calls their report that they send back to you for your quality ACO stuff. And pediatric community hasn't seen those yet, but you'll start seeing them this summer if you are in an ACO. Who tracks them down? Who's going to find who didn't get vaccinated? What are you going to do about it? Is it someone from the front desk? Is it a nurse? Are you going to send alerts, reminders, figuring out some things like rooming the patient, standing orders? Turns out these are two of the most effective things you can focus on improving vaccination rates are rooming patient and standing orders solutions, which we'll talk about in a few minutes. Working through your workflow. And so here's an example from an actual clinic who used just sticky notes on a white paper to kind of work through their workflow. Another clinic that put theirs together. This is nice. Using a program like this means this workflow can be modified from time to time and adjusted and printed out and given to everybody. So I like this kind of an approach. Some people will ask me, why don't you just give me the magic workflow? And the answer is because I can't, because every clinic is different. Every clinic is staffed differently, has different size, resources. Some interventions may or may not work in your population or may not be doable with your EHR, for example. There are enough unique factors about every clinic that nobody can give you the magic diagram. You really need to create it yourself. The other evidence shows that if you create your own workflow, it'll be much more effective. So you should look at your things that you might do, such as team huddles, standing orders, reminder systems, things like that. You as your group should discuss this and talk about it. You may even use something low tech, like in the old days when I first started my clinic, we actually had 3x5 tickler files for recalling pap smears, for example. You can go that low tech if you need to, but most EHRs do have some way of doing this. So figure out what your EHR can do. Then create your workflow diagram based on which staff you have, which interventions will work in your clinic and that you have buy-in to achieve and the resources to implement, and then use that to create your workflow diagram for your clinic. I like this example from April Brinkoff here in Lincoln, where she did her cancer screening project and encapsulated it in one picture where she actually used her baseline data, her final data, her two workflow diagrams. They talked about it as a clinic, just circled who was doing best, came up with ideas right on the whiteboard. And here in one picture you can see a year's project summarized with one pick. Communication is important. One of the most important things in clinics is that sometimes communication channels don't work the best, and so you need some open discussion. People need to be willing and able and feel safe to provide suggestions without someone shutting them down. You need to look at your progress and review it regularly. You need positive competition. Rank and spank does not work in most medical environments, and that needs to be a team approach. Everybody in the clinic should know the role they play, and so the clinics who do it best when they have these presentations, it's not just the physicians, it's actually the clinic, including front desk and back office, that pretty much determines a lot of times clinics do better or not. Some examples of who's doing better or not, what I see over and over again with clinics, and I've worked with dozens of them now, the clinics that do it well will often when the first time they pull their report, we'll find that they've got bad data. Essentially, all these bubbles down here are bad data. They clean up their report to get it accurate, and you'll see a massive improvement, usually between the first and second reporting period. Then what you then start seeing is this incremental process. This is true quality improvement work, because the baseline probably wasn't here; it was actually way up here, but you start seeing incremental progress. Frequently we'll see a clinic that almost nothing changes, and that means they probably had a meeting, they talked about it, and then just nobody did anything afterwards, and they didn't continue to talk about it. They didn't actually institute anything. Whereas this clinic here, you can see this clinic wasn't too bad at their baseline, but you're seeing incremental progress. So these are probably true numbers. Most of these are probably still bad data because people really haven't gotten together, worked on the reports, and done something about the issue. As some of you know, we've got a community group that meets periodically at the Harbor Coffee Shop, and we talk about what's working and what's not working in our clinic. And this is basically everybody's reflections from the folks around the table, a group of pediatricians and family docs here in Lincoln. So here are the things that they found that worked when they found some improvements. One is making sure that people know that second dose, you can't actually give it before 6 months. It can be given at 5 months, 8 days, and that's still okay. So you don't turn away that opportunity when it's there. So make sure people understand that. Over and over again, we hear about the idea of giving the vaccine before the doc works in the room, assuming that mom or dad's willing. It fixes a couple of things. Number one, you don't have that extra delay. Some people like to delay and let the patient sit there for 15 minutes after the vaccine. That gets rid of that delay, so it's a time issue. Others said that actually it takes something off the agenda. Sometimes you have an anxious adolescent worry about the vaccine. If it's given ahead of time, it basically takes that off the table so you can have a better discussion afterwards. Standing orders, multiple people said that standing orders made a big difference in giving the vaccines routinely before the doc enter rooms if there's no questions. Pitching it as a cancer vaccine. There was a huge mistake when they billed this as human papillomavirus spread through sex. They should have focused on this as a cancer screen initially years ago and probably caused some harm due to bad marketing. So we need to just tell patients this is a cancer vaccine. You want to get rid of cancer. Again, some people use the AAP sheet. They use handouts ahead of time so that parents are sort of preempted. That's actually a psychological technique called priming, or even sometimes vaccination, where you actually give people information ahead of time to preempt a discussion 1 or 2 weeks later. So some folks used sort of a communication to mom and dad as a way to increase their vaccination rates. Other ideas, again, sending a text message. So some people did email, some did text, some did a letter in the mail to kind of prompt this and get parents thinking that yes, HPV is recommended. We are going to push out this year at Lincoln through Lincoln Public Schools a letter from the County Medical Society encouraging parents to vaccinate their children for HPV. Sometimes doing an opportunistic thing where you can catch the younger sibling. So you've got an 11-year-old for a 7th grade physical and the 9-year-old sister is in the room, or brother. You could get them too and then have them both come at the 6-month return to save mom and dad a trip. Having a nurse or a care coordinator who could practically run through the list for folks who need vaccines, especially when they're coming in anyway. So sometimes people would get actually improvements by catching the kids at other times. A kid comes in for a sprained ankle but is overdue for a vaccination. You could go ahead and give that HPV at the same time. Also, of course, there's no replacement for having great staff. So having a CMA who borders on stalker trying to track these people down for you is really, really helpful. And those folks are sometimes worth their weight in gold working for you. The data behind this is getting better and better as far as what makes a better primary care office. This is a nice article which I'll also send out if you're interested in it. They actually went through the key attributes of clinics that had both really high quality care and lower costs, and they broke down to 6 things. And some of these apply to what we've been talking about. So support for evidence-based medicine, the fact that you go through as a clinic, say this is the right standard of care and we're going to follow this, here's our standards, made a big difference. Having care coordinators does make a difference when people who can go through those gaps in care reports. Standing orders and protocols are also been shown over and over again, especially for vaccination efforts, to make a big difference. And so taking this out of the physician's hand and giving it to a really engaged and empowered nursing staff sometimes is the best fix you can do in your office to improve your vaccination rates. So that's the whole presentation in 14 minutes. So if you have any questions, let me know. Thank you for your attention.